Good evening. My name is Wade Green, and this is the final project for the patient-oriented outcomes course with Dr. Valier. And the title of this presentation is the HIT6 and MIDAS: Application, Properties, and Implementation. We start off the presentation with a case report of a 20-year-old tight end that reports to the athletic training clinic complaining of a headache that's been present for 1 week. This young man has a very complex concussion history. He has a prior history of 2 reported concussions, one with a loss of consciousness, both of which were before his collegiate career began, and both of which also resulted in questionable management strategies. He also notes that he has experienced headache at least 2 to 3 times a week, apart from any other concussive symptoms, but believes these headaches to be normal. The patient denies all other concussive symptoms, including dizziness, sensitivity to light, difficulty concentrating, and others. A balance assessment reveals 2 more total errors when compared to baseline best scores. So given this young man's concussion history and given his symptoms, an impact is conducted, and it's found that his verbal memory is in the 34th percentile compared with the 79th percentile at his baseline, 43rd percentile in visual memory, with 74th percentile at his baseline, visual motor speed in the 52nd percentile with his baseline at the 69th percentile, reaction time, the 29th percentile with his baseline at the 70th percentile. His impulse control is a 9 at is a 9 post-injury versus a 2 at baseline. And the only symptom that this young man is reporting is a headache, but with a symptom score of 4 on impact. So both the team physician and the athletic trainer make a decision to treat these symptoms like a concussion, even in the absence of of any known mechanism of injury or other concussive symptoms. So if we were going to go ahead and attempt to apply this to the ICF disability model, we would go ahead and start with the health condition, which would be a mild traumatic brain injury or a concussion. The impairment that's experienced by this young man is headache, and the limitation that appears to be taking place from this headache is that normal, daily activities, as well as class attendance, are actually causing increases in headaches, specifically. As far as restrictions, and I apologize for apparently there's been a formatting error, but restrictions have been up to this point no participation in practice or any team workouts. There are a few different factors that are affecting this case. Some environmental factors such as pressure from coaches and a lack of knowledge of medical history by the coaching staff. Personal factors as well is this young man's lack of past concussion history and also lack of symptom disclosure to the athletic trainer and team physician. So as we move into the second part of this project, we've identified 2 possible outcome measures that we would use with this patient, the HIT6 and the MIDAS. But first we'll focus on the HIT6, which stands for the Headache Impact Test, which is a short form. And so this instrument follows a Likert type scale of 6, 8, 10, 11, and 13, which corresponds to the 1, 2, 3, 4, and 5 respectively on a typical Likert scale. Scores in the HIT6 range from 36 to 78, and a higher score on the HIT6 denotes a greater impact of headache, whereas a 36 would be no impact. So when it comes to selection criteria for the HIT6, the HIT6 does really well. The HIT6 has been shown to have a Chromebook's alpha score of 0.89 to 0.90. on test-retest administration, which means that the questions within the instrument do a very good job um, of measuring what they're supposed to measure with repeated tests. Concurrent validity for the hit 6 was good to excellent when compared to the short form 36. And then, according to a study by one of our professors at AT Still, Dr. Valier was an author on this study. The MCD value for the hit 6 is a 3 with an MCID value of 5. So we wouldn't necessarily deem anything below 5 as clinically significant. The MIDAS specifically is a 7-item scale intended to assess the frequency of migraine symptoms. And the scores on the MIDAS basically produce a much larger range from 0 being no disability to 270 being severe disability. Now there are some definite differences here with the MIDAS. The MIDAS has been shown to have good internal consistency with a Cronbach's alpha of 0.83 and good test-retest reliability at 0.84 with the MIDAS. But you know, in preparing for this presentation, there was no known MCD or MCID values for the MIDAS to my knowledge. So selecting an instrument, this is where it can get challenging. Looking at the literature and letting that guide our decision, Sara et al. made key observations in their study regarding comparisons between the MIDAS and the hit 6. It was noted that there was a higher correlation between the MIDAS and the Beck depression inventory, while the hit 6 and the BDIA and the Beck depression inventory were not significantly correlated. I definitely see that as a positive, actually, for the hit 6 because it's actually measuring more of the construct of headache, and it is not there's not so much of variability inside of the instrument that it can correlate with other constructs. Now, although the hit 6 has been proposed to rank individuals as having greater severity of headache than they normally may, once again, the amount of variation within the instrument itself appears to be less. So how would we measure change with the hit 6? Change values have been given for the hit 6, and once again, we know that we have a range from 36 to 78. MCD values for the hit 6 have been suggested as 3 units of change, with the MCID values the minimal clinically important difference being as small as 5. So, having said that, I wouldn't attribute any change in the above patient status of less than 5 points as clinically meaningful change given the above information. So, moving on to implementation. The primary application of implementing the hit 6 in the above clinical scenario is to distinguish concussive features of headache from its non-concussive features. We essentially want to find a way to attempt to assess headache on a broader scale and be able to really, hopefully, discover some nuances and really tell the difference between what our patients are experiencing when they are concussed as opposed to maybe just a normal day with, potentially just, a headache. So in order to do that, the hit 6 would be administered during baseline testing prior to the start of each fall season in August. Then again, after a concussion has been identified, and then once the patient has been symptom-free for 24 hours or more, we would administer a test again prior to neurocognitive testing. So we would essentially treat this just like we treat our neurocognitive testing. Our current practice setting at Hardin-Simmons University, where I'm employed, utilizes an electronic medical record to keep track of all of our documentation. The good thing about our EMR is that it's fully customizable and it is web-based. And we have the ability to create various PDF forms and online forms within our EMR. And after meeting with our EMR administrator, the creation of online forms provides an electronic format to the collection of the HIT6, which would essentially allow us to just enter those values into the computer and track our outcomes that way. So, in conclusion, the HIT6 was the pro that was chosen given the above scenario. And the HIT6 has been shown to have excellent construct validity and is also very sensitive to headache, which we believe to be the most important given the above scenario, since that is the patient's only recorded symptom. Strategies for implementation and usage have been outlined with a clear framework for collecting and tracking this pro. And once again, we hope that with the use of our EMR, we should be able to readily implement in a user-friendly format with increased feasibility and acceptability, be able to implement this. So, thank you very much. And here are our references.